I'm Evan Johnson. I'm an assistant professor at Columbia University, and I work with the NYP-OC Spine Hospital.
My name is Rick Placide. I'm a professor of orthopedic surgery at the Virginia Commonwealth University in Richmond, Virginia.
So Rick, we've had the great pleasure over the years of presenting together, or at least I've had the great pleasure of presenting with you over the years on differential diagnosis and looking at the human body and the spine beyond just the one region and the interaction of regions. This year we're looking at neural and organic and orthopedic causes of pain that can mimic spine pain, or what you like to call spinal masqueraders.
Right.
Perhaps you could talk a little bit about what the form the presentation will take and your thoughts on the subject.
Right. So we use the term spinal masqueraders. There's other terms, mimickers of spine pathology, and it applies to the patient that presents to the spine clinic with signs or symptoms that seem to be spine related, but it's completely unrelated to the spine. They could have an orthopedic issue like a hip or shoulder problem. They could have a neurologic issue like multiple sclerosis. They could have some organ system problem like a lung tumor masquerading as a spine problem. And that's sort of how this interest is generated, and essentially it's a differential diagnosis.
Yeah, we're in such a technologically advanced medical community now that it seems that we're graduating an awful lot of young physicians and young physical therapists and young healthcare providers who have maybe somewhat less physical exam skills and rely heavily on MRI, CT scans, laboratory tests, and so forth. Do you see that as part of the issue in terms of differential diagnosis and these masqueraders, how one orders those tests and also the physical exam component?
Absolutely. And it's not just my opinion. There's a growing body of literature referring to diagnostic errors. And some of that has been, some of the problems, meaning the wrong diagnosis being made, is being traced back to an inadequate physical exam and an inadequate history. So for example, a patient may present and already have those advanced imaging studies like an MRI or a CT scan, and it can be very misleading. They show such detail of the anatomy and sometimes what is abnormal anatomy, but maybe have nothing to do with the patient's complaints.
Interesting. And so, and then this is interaction, of course, that we all see with medical comorbidities, right? So the patient that both has a diabetic neuropathy and perhaps also a spinal condition and a myelopathy. So they might have a lower motor neuron and an upper motor neuron issue working at the same time. The presentation can be obscure or can be confounding, confusing. What are your thoughts as you teach? And I know you teach in a residency. It's a big part of your practice as well. What are your thoughts in terms of the best way to delineate those problems and the best way to get to the source, to the extent that there is a source of the problem?
So if you have a patient with multiple comorbidities and they may have a superimposed spine problem, understanding the natural history of all of those conditions is important. And the history very often tells you more than your physical exam in a case like that. Because you're right, the physical exam will be altered, particularly the neurologic exam in somebody with diabetes, for example.
In terms of recent cases, right, we'll be presenting cases here at NASS this week. In terms of recent cases that you've seen, anything stand out? I mean, we've talked about hip spine, patients who have degenerative joint disease of the hip that presented like spinal patients or facet joint or maybe even radiating pain halfway down the thigh, right, so forth and so on. Beyond that, maybe something even more obscure. Any patients that have come your way recently that really caught your attention?
So recently, it was a 70-some-year-old gentleman that had previous lumbar spine decompression surgery, laminectomies, and did okay for a little while and then started losing the ability to walk. He still had back pain and some leg symptoms, numbness and tingling, but his biggest problem, he had extreme poor balance, went back to his spine surgeon, went through multiple rounds of physical therapy, and ultimately came for an additional opinion. And this is now going on for nearly 3 years, and he's almost wheelchair bound. So we scanned the rest of his spine. We were a little bit unclear as to where this all was coming from until we stepped back and redid the review of systems, and the family was in the room. And it was very interesting how the family was trying to explain away other parts of the review of systems. So for example, okay, you're having gait and imbalance problems, you can barely walk. Looking at all of the other systems, a couple stood out. Oh, he has some urinary incontinence. Yeah, but he has prostate disease. Oh, he has a little bit of cognitive decline. Yeah, but he's 75 years old. That was the answer from the family, but scan his head, and you guessed he has normal pressure hydrocephalus.
In some ways, that calls for more thorough testing, right? Maybe more thorough scanning. On the other hand, society is moving away from that, and we're talking about the physical exam aspect.
Yeah.
So how could you have clued into that, save this individual maybe 3 years of grief and degenerative changes? How could you have clued into that, or how could a clinician have clued into that more readily without the excessive exams?
So, right, and that excessive amount of time, I think it goes back to understanding the natural history. The patient did not have lumbar spinal stenosis anymore. He had surgery, and the follow-up clinicians kept focusing. They repeated MRIs of the lumbar spine. They did not go to the next level. So it clearly was not a condition that is related to lumbar spinal stenosis. It was the problem, he had diabetes too, so his reflex exam was altered. We did not have a good reflex exam. On a physical exam, I don't know how you would have picked that up. It's more of the history.
Got you. So in terms of the masqueraders, what we're speaking about today, another instance would be the individual has an orthopedic issue, right? Whether it is an orthopedic issue in the shoulder, right, that causes a cyst to form that then affects the suprascapular nerve, right? Or one of the cases that I'm talking about today is an individual who, while she had a small hamstring tear, right, an active 40-year-old physician who ran marathons and so forth, and while she had some SI joint dysfunction, and while she was tight at L4, L5, with some effacement of the L5 nerve root, had treatment for all those conditions for years, injections and so forth, epidural steroid injections. And it resolved into the fact that she had a ganglion cyst that was sitting at the inferior gemellus and catching the sciatic nerve, a 4 centimeter by 2 centimeter cyst. So I think as we talk about this, we could talk about it in the abstract, right? But ultimately there's a lot to be said for poking, for prodding, and maybe, once you're in the rabbit hole, to recognize you're in the rabbit hole, right? So after she had 2 injections that worked, 2 transforaminal epidural steroid injections that worked, right? And then 1 that didn't, right? Rather than another image of the spine, at some point one is thinking, hey, right? And not rather than another hip x-ray, right? Yeah. What else, what other structures outside the box, right? Outside the common might I look at?
Right, so that's actually a very difficult case, and that would be difficult because in that case the history is not overly helpful, right? That's been ruled out. Your physical exam could be helpful to a certain extent, maybe a very detailed sensory exam, reflex exam, because you're checking spinal levels at that point, and good motor testing, maybe neural tension testing. But I tell you, that would be a difficult one to pick up on the first few visits. Very often people go through a variety of interventions, as you mentioned, and some help and some don't. Well, you have to use those as diagnostic clues.
So maybe the art of what we do and the art of spine care is not just about the creativity, but also about sequential differential diagnosis and being willing to change course and having an open mind, approaching the patient with the open mind when what the common explanation fails, one's willing to look outside the common explanation and look for further results, which I think most of us do in our practice. I hope we do.
Well, I think unfortunately there are a lot that don't, and I think that's a critical point, is keeping the open mind. One of the things we teach is that if your physical exam and your history does not fit a particular diagnosis that you see on an imaging study that's already been done, don't make it fit.
Thanks, Ray. That's great.